Right, morning all. So let's move on to my slides. My name is Richard Croker. I am a clinical informatician here at the Bennett Institute. Been here about 10 years. But my other job is, when I'm not doing this, is chief pharmacist for primary care at NHS Devon. Population of about 1.2 million, got about 120 practices. Prescribing budget, as in relevant today, of about £230 million. So a reasonable size, but still small in terms of national picture. Really great that all these things have come together. So we've talked about the prescribing. There's another prescription, a blank one. Most common intervention in primary care, we all know that. About 1.25 billion prescriptions dispensed in the last 12 months, latest data we have. It's now up to £11.2 billion, Ben, in primary care. All those pharmacists need to be paid for that. And it is basically what we use is a byproduct of that reimbursement data is the accurate granular data. Now, I've crossed out prescribing because, as Kerry's just said, actually dispensing is a different process. If a patient doesn't take their prescription to the pharmacy, get it dispensed, we never see the data. So they are really common commonalities between the two, but one is a subset of the other. Very quickly, brief history. Ben's already covered some of this. I will be playing an occasional game of, is it the 10-year plan or is it older, through this presentation. J.P. Martin talked about this in 1957, that they had to set up a large-scale administrative machine in order to identify and, where necessary, penalise excessive prescribing, which was defined in 1964 as 1.25 times the average cost of a doctor in the executive council area, whatever that was. So this depressed me slightly because when he's talking about setting up that administrative machine, that was for the 1911 National Insurance Act, not the National Health Service. So people have been doing the sort of job that I do in primary care for over 100 years. So it's quite depressing that we're still having to do it. I'm not sure if you can see this, but I pulled this out of a paper from 1952, looking at what was the most common prescribed thing in the 1950s. And you probably can't see it, but the top item prescribed was barbiturates and bromides, followed by stomach tonics. So a very, very different lot of things that were prescribed. About £41 million spent in 1951, which was the last year before prescription charges came in, which they bought in because they were spending too much money. That's about £1 billion in today's money, so about a tenth of where they were, but clearly, hopefully less barbiturates in 2025, hopefully. Moving on to the 1960s, somebody sent me one of these the other day. This is, as Ben was saying earlier, this is basically open prescribing, but somebody sat in an office typing them up. And I don't know whether they were coloured in by hand, but exactly this. This is how much you're spending on per drug. This is how much you spend on average. All these things are happening. By the time I joined the NHS as a prescribing advisor at the end of the last century, it had moved to computers, but it was still the same. And none of this was really publicly available. So we used to get this as a pack catalogue. Really granular data, showed you how much quantity of every prescription was being dispensed. It turned up in a big box with all of your practice's data. I could get that in the NHS. We got it through EPACT, originally through an ISDN line, ask your parents, then through the internet, then onto EPACT 2. But none of that stuff was publicly available. We did have some publicly available data, but it wasn't very granular. It was much more about cost and items across the country. Then in 2011, the autumn statement talked about all practice-level prescribing data being made openly available by 2013, but actually it came out a bit earlier than that, which leads us to the English prescribing data set produced by our friends at the Business Services Authority. It comes out every month, and that is exactly what we have. It's granular practice-level data. Comes out about 8 weeks after the corresponding end of the corresponding month, but it's not one for Excel. People have tried it in Excel, but you just get that. The latest data, so that was September 2025, it's about 7.5 gigabytes, 18 million rows. So a big chunk of data, not something you can just go through by hand. That's what it looks like. Not very interesting, but a lot of things in it. It has individual rows for every quantity of every prescription dispensed, so we can see separately how many patients received how many items received for 28 or something versus 56 or something versus 84 or something. I'm a pharmacist, therefore I only think in a 28 times table. How much it cost and the total quantity overall and various other things. We've started to see SNOMED codes, which gives us much better granularity, talking about your VMP and AMP. DMD codes, yeah. SNOMED DMD codes. They call it SNOMED codes in the file itself. So I came to think about how I used this, and I suppose I have two jobs. One of my jobs is working on Prescribing, making tools, bits and pieces. But my other role is using the data that we use in things like Prescribing in order to make prescribing better, more cost-effective, more safe, and all those sorts of things. So how do I use that data? Thought about it quite a bit. There's a tool, I don't know if you've heard of it, it's called Prescribing. It's quite good at doing these sort of things, taking all of that data and giving really good actionable insights so that me in the NHS can then look at that and go, oh, that's a bit strange. What do we do in order to change things? So I've picked my own ICB because I thought that was probably fair. And some good things, some bad things. So we are really high, for some reason, in Devon on the 21st century version of barbiturates. So anxiolytics and hypnotics were really high. We don't understand why. But having this data allows us to find what we need to do about it. And using this data, we have worked with practices to really reduce their data down significantly. A big thing at the moment is cost effectiveness of DOACs. We have actually done some work. You can see we were quite high on our higher spend DOACs, and actually we've done some work recently in the last few months to change that. So we've got patient safety, we've got cost effectiveness, we've got sustainability. We have measures on Prescribing around the mean carbon impact of OSAB1 inhaler prescribed, because there's quite a bit of variation between different brands. And efficacy, so vitamin B complex, not really very useful. A lot of prescribing going around. We were able to see that actually back 5 years ago we were really high. And by using Prescribing, we could then do that piece of work to find out, yeah, we're high, what should we do about it? We did something about it, and then you can see that we can track our successes there. So a really powerful tool for actionable insights. The Prescribing side, we can take some really good data science stuff. This is a modified QSUM method for finding change, I think. And we take that at Prescribing and we make bespoke alerts for anybody who wants them that says, this is my ICB again, that we were really good at amoxicillin prescribing small quantities. Actually, it's starting to drift a bit. So now we get an email to say, you're drifting a bit. Allows us to think, oh, right, what's going on there? Let's do something about it. So the actual insights is really key for use of that data. Service analytics and research is also really important. This is a Bennett Institute paper from a few years ago. Did the Chief Medical Officer have a writing out to practices say, please do something about antibiotics? Did it change behaviours? Actually, we can't show causation, but there was a good correlation to show 3 minutes. Okay, thank you. A good correlation to show that actually, yeah, it probably did. We did a piece of work on people switching antibiotics from trimethoprim to nitrofurantoin, and we were able to look at what was good and what was bad, and found out that those CCGs, as it was at the time, that had good formularies, good incentives, simple, actionable insights for them, actually showed better behaviours. So you can do all that. We can even use the data to find slightly odd prescribing. This is a favourite of ours. This is perazizine. I think it has 78 references in PubMed. It's an antipsychotic. One of those references is ours about this paper. Not used anywhere, like 0.25% rest of the country. In Norfolk, 1 in 5 antipsychotics is perazizine. We've asked Norfolk, they don't actually know why, but finding that variation out, finding out why that is really, really important to us. We found a problem with System 1. It was causing high-cost branded generics to be prescribed when they didn't really exist. System 1 were great. They found it, they fixed it. They're a really, really good piece of work by them. Saved several £1 million in the NHS. It's not just us that does this data, though. There's lots and lots and lots of people do lots of research in the data. But you have to be thoughtful with it. Going back to what Kerry was saying earlier, that prescribing data set in the practice is really good. But in the English prescribing data set, we know what's been prescribed and we know how much it's cost. We've got no clue who it's for, and we don't know what it was for. And therefore, we have to be much more careful thinking about what good looks like, because we don't know whether any of that prescribing is appropriate. So I've already talked about perazizine. I think that's probably a relatively simple one to work out. Is that normal? And what does it mean? But it's good to have the conversations with people to find out what's going on. I had to recreate this because the data's a bit old. This is Freestyle Libre, so continuous blood glucose monitoring. 3 ICBs across the country. Which one's good and which one's bad? Do you want to be high? Do you want to be in the middle? Do you want to be low? You want to be 1 minute? Oh, you weren't going to give me the answer? Okay. I don't know the answer to that one. But it's interesting, there it is. This was a classic one about being thoughtful. Cost of serotonin, SSRIs for depression massively went up in March 2020. Any ideas why? It was actually the cost of sertraline went right up. Had nothing to do with the pandemic whatsoever. In fact, the growth of antidepressants was higher in the 12 months to the pandemic than during the pandemic. So, also, how do you compare it? What do you compare it with? This is something that I battled quite a bit of time. Do you compare A versus B? Do you compare a list size? Do you have a specific denominator? 40 years ago, there were prescribing units, so older people were weighted more than younger people. You had AstroPUs. We in MO love to talk about AstroPUs, but they haven't been updated in over a decade. Even when they were done, they had an R-square value of about 25%, and it wasn't for individual items, but MedSop folklore loves to talk about weighting stuff by AstroPU, completely incorrectly. And then we have StarPUs, so specific individual bits. I don't think they've been updated in a decade either, and we've asked who now updates them, and we haven't been able to get an answer. So we've stopped using them because you just end up weighting something. Medicine moves on. So here's one of my questions, which is this the 10-year plan? So scientific developments in pharmacy revolutionized manufacture selling of drugs, resulting in more expensive forms of treatment. Increasing population entering older age groups has been a corresponding shift in the incidence of disease to the complaints of old age. 10-year plan or not? Yeah, it was. Oh, no, I've killed it. I haven't killed it. There we go. Well, I'll go back anyway. So it was 1957, and social aspects, social aspects of prescribing, which is also a bit depressing, so I'm pretty sure the 10-year plan also talks about population shifts as well. That is a blank slide. So I've got, 20 seconds left, something like that. This data is really, really useful for clinicians and people like me in MedSop teams for actionable insights, really, really useful for service analytics and research, as long as you understand what your limitations are and are very thoughtful of them. Final slide, 10-year plan or not. Technical advances are being made, transmitting information in a concise and useful form is bound to become more and more important, and any effort would be a useful contribution to the administration of the NHS. Who won? Not. What year? 1587. Close. It's the same book again. I was just cheating. But yeah, so things have changed and nothing has changed. But please come and talk to us tomorrow about using that data if you want to know more. Thank you very much.